All right, so I'm very honored to have as our guest on our Pacific Neuroscience Institute facial nerve webinar series, Dr. Shiayin Yang, or otherwise known as Xia Yang. Dr. Yang comes to us from Nashville, where she is Associate Professor of Otolaryngology. She's in the Division of Facial Plastic and Reconstructive Surgery. She has uh, amazing experience having trained at University of Michigan, for her facial plastic and reconstructive fellowship, which is one of the most prestigious programs in the country. And she's joined the team at Vanderbilt. And the reason I reached out to her to speak today was because of her recent publication studying the incidence of underlying mental health disorders in the facial synkinesis population, which is something that all of us who manage patients with facial paralysis are cognizant of, but does not get enough attention, I believe, and I think many of our colleagues would agree. And so her putting this paper together with her incredible team was a breath of fresh air. And so I wanted to invite her to discuss the topic with us and share her insights. And we look forward to your presentation. Thank you so much for joining us.
Thank you. So I actually didn't put together a presentation, but so I apologize. I don't think I was aware. But I do have enough and plenty to say about it. So we actually have 3 studies that we did, and we specifically looked at non-flaccid facial paralysis or synkinetic patients. The reason being because every time I see someone in the office, they tell me that that they didn't think anything could be done. Their, physician, whoever referred them, was like, well, you've recovered, so there's nothing more that you can do. And so a lot of people are like, well, I thought this was vanity, cosmetic. There's nothing I could do, but it's affecting my everyday life. And I feel embarrassed to come and get treatment. And I would hear this over and over again. And it just was so evident how much of a mental health toll happened. So I decided to look at our patients here in Nashville, and we have a pretty good cohort of patients with synkinesis. And what we just decided was to survey patients and see how many people are expressing depression, how much anxiety is there. And when I did a literature review, there was data on patients with flaccid facial paralysis. So those patients maybe after a skull-based tumor or malignancy, and that might be a little bit more obvious because their full face isn't working. But for the synkinetic patient, I couldn't find any data on it. So we did a survey where we asked our patients, we gave them a survey looking at depression as well as anxiety. It's not a diagnostics tool, but it's more an indicator of, are these present? And then we had them fill out SAQ, we had them fill out FACE, and then the physicians also graded them with Sunnybrook and eFace. And we found a lot, honestly. So just in terms of like the overall population, the lifetime incidence of depression within the United States from large database studies is about 17%. And then in terms of anxiety, there's been a reported 34% incidence over a lifetime. And this is just the general population. And what we found in our patients with synkinesis is that 25% of patients met criteria for probable depression. So that's almost 10% higher than the general population. We also found that most patients had severe anxiety. Their scores qualified for severe anxiety. So already, a pretty significant burden in terms of depression and synkinesis, or depression and anxiety, excuse me. We then looked a little further. So there have not been any studies showing the correlation between patient graded scales. There are a number of different patient graded scales, some that I mentioned, as well as physician graded scales. And we didn't find a difference in terms of, they tended to correlate. So if a patient views their synkinesis as severe, physicians tend to also view it as severe or grade it as severe. And there was a pretty good correlation between those 2 scales, which I think is extremely helpful because we rely a lot of these surveys on how we treat people, but how they view themselves, if we view it differently, how do we apply that clinically? So if you think of, for example, in my recon patients, in my Mohs reconstruction patients, I may see a scar on their cheek. And I think to myself, okay, I could improve that appearance by either excising it, by doing laser, by doing some type of microneedling. But if it doesn't bother them, then I don't do anything. And so this also applies to our synkinetic patients. If they are scoring very low on these scales and their synkinesis doesn't bother them, but I notice it, is it my prerogative to treat them? No, it's my prerogative to take care of them and fulfill the goals they want. So I think this was an important finding showing that these scores correlate well, or these surveys correlate between the physician and patient graded. So then we went a layer deeper. And what we actually found is that patients who had higher scores of depression or anxiety, that their severity and how they graded their synkinesis was then it blunted that correlation. So they were less likely to be in agreement in terms of their scores with the physician-based scores. So that's when we found a disconnect between those two surveys. And that is important to understand because as a physician, if you were providing chemodenervation or Botox and you look at it and you're like, you're getting a great result, but they themselves feel that they aren't, I think that's very important to understand that there might be this mental health component that's influencing how they're viewing their synkinesis. And then subsequently, how are they viewing how we treat them? So that was the third prong to our study, was to determine how Botox patients with facial paralysis or synkinesis, as well as depression and anxiety, how does that influence their treatment? So how does that influence the results they see from Botox? And what we found is that female patients who are younger, patients who had a prior history of anxiety and depression, that they tended to not see as much benefit from the chemodenervation. And they didn't show as much as an improvement. So I think all of these things were great findings that we haven't really talked a lot about. And I'm sure you have seen a lot of patients come in that I've seen patients who say, you know, I self-isolate, I quit my job, I don't go out to eat, I don't socialize. And this is just a part of the disease process that we really need to address and treat and take care of. So I think having an understanding of that as a provider is very important, but also having an understanding of that as a patient is very important because even just with other medical conditions, the healthcare burden associated with mental health disorders is significant. And additionally, with other medical conditions, studies have shown that untreated mental health disorders influences their treatment for other medical diseases. So really treating the person as a whole is important to optimize the outcomes of their treatment in synkinesis beyond chemodenervation. I mean, a huge part of surgery, especially plastic surgery, is expectations and making sure that we can achieve what we think we're going to achieve. And I think part of that is a mental health component. There's a lot of patients who I will delay operating on because I think I tell them you need to be in a better headspace and you need to be ready to have this procedure because essentially surgery is that trauma all over again. And it's reliving that experience of having your face paralyzed and going through this huge change in your identity and who you are. And so honestly, that's kind of what led me to look at this and the repeating theme amongst my patients of how much of an impact this has, because this is how we communicate to the world, how we eat, how we present ourselves. And it has such a huge impact on who we are as people that I think it was something important to discuss and look at, and something that we really haven't put that much effort, I think, and time as it deserves.
I think that's great, and I appreciate you coming on today to share your background with our patients because it's we see this every day. Probably take it for granted that we think everybody knows what synkinesis is, and that all patients who experience it, have done, have gotten to see like what we would describe as vetted sources of information. And unfortunately, patients who are suffering have a very hard time finding good resources. So knowing that the work that you're doing is out there, and we can link to your article for people to take a look at, um, uh, we can, at least let them know that there's certain institutions and places where people can go. One of the things that I found interesting from your study was specifically age. Um, you know, and I think this is something that we'll probably need to do a multi-center study, but in your experience, do you find that there's like a cutoff in the sense of when someone may or may not develop uh, more or worrisome signs for depression or anxiety if they develop synkinesis or develop Bell's palsy or Ramsay-Hunt, or facial paralysis in general, below the age of 16 or 20 or 25 or 30? Is there an age range that you may focus on a little more intently?
Yeah, so that's a great question. I think there's two things that I have noticed in my practice. Age is one of them. And so, specifically in terms of an exact cutoff, I'd say anywhere in their 20s and 30s. That being said, it can affect anyone at any time and age. I have patients come in who are in their 70s and 80s, but I would say more commonly it's patients who are in their 20s and 30s who are female. And our patient population is significantly skewed to female. We know the incidence is generally 50-50 in terms of developing synkinesis, but my patient population is about 90% female. And that's another area I'm looking into, is why is there this gender difference in who seeks treatment? But in terms of the mental health disorders overall in general, and this may have skewed our study results, is that we know there's a higher incidence of anxiety and depression amongst females. And so does that skew our results amongst our facial paralysis patients as well? But really, it's those younger patients. I also find that the closer they are to the diagnosis, the more likely they are or could develop one of these mental health disorders. So depressive symptoms, anxiety, because this disease is new to them. They're learning how to grapple not only with this disease, but how to function in their everyday life. So those are kind of the key points I look at. I look at gender, I look at age, and I look at the time from onset. But truthfully, I just talk to them. And as you probably notice, these visits are longer. It takes a lot of time, and it takes a lot of time to understand it. And it's really just talking to people and understanding, how is this affecting your everyday life? How is this affecting you? Because some people won't, I don't think they fully let their guard down about it, because they feel like, I hear a lot, well, it's not cancer, or I'm not dying from this. And I have to tell people, it doesn't matter. It still is a significant disease process, and it's something that significantly affects your everyday life more than just appearance. It affects how you function. And I think really just validating those feelings, validating that it's not just cosmetic, that it's not just vanity, that it is a disease process, is important. Because I haven't had this disease, and to have to go through something like this, I really empathize with my patients. So I do take those into consideration, but also just really talking to the person. And if you're able to spend enough time, you can tease out how it is affecting them, and if it is, causing any type of depressive or anxiety type symptoms.
In your practice at Vanderbilt, do you have a psychologist or a therapist that you can refer patients to within the university?
So great question. I'm still working on that, because after COVID, a lot of people stopped taking insurance. So I have some people who I do refer, but they don't take insurance. So I'm still trying to work on. And the department here at Vanderbilt started limiting how much outpatient stuff they're having. So that's been a little bit of a struggle. I do direct some of my patients to Facebook groups that they have told me about, and really just kind of support systems. There is a small support system at Vanderbilt more for skull-based patients, but just trying to find support systems I found has been beneficial. But the psychologist one is honestly something I'm struggling with in terms of finding people who take insurance instead of private out-of-pay. I don't know if you've had that experience.
Yeah, so we have in our group a person who has trained in psychiatry and specifically neuro-oncology based psychiatry. So patients who've had skull-based tumors like meningiomas or a vestibular schwannoma can see that doctor and can get treatment. And so we have had some success in that patient population, but unfortunately, they just aren't able to see patients who don't have, haven't had a tumor.
Yeah.
So for the overwhelming majority of our patients who are Ramsay-Hunt or Bell's palsy or Lyme's or something infectious, they aren't able to see them. And so we've tried to refer them to either local therapists who I guess, if they take insurance or not. And then also there's somebody I recently met with who's a cognitive behavioral therapist who works with patients who have body dysmorphic disorder, who's interested in this patient population. He used to work at UCLA, but he also is only cash. So it is something that's tough. I liken it to almost like PT because you can go see any physical therapist, but there's very few that focus on the face, as you know. And so finding a therapist who understands what it's like to experience, facial synkinesis is also not that easy. But
Yeah.
but I think it is more of us in the community of surgeons and doctors that are taking care of patients like this or getting the word out of how important it is. Hopefully, it's something that we will be able to, find someone, whether it's in our practice or within our community that, could become a go-to.
Yeah, agreed. I think, and this is part of why I did it, the more we can spread the awareness and the more we can spread the understanding, I think the more we can help patients. And I really, part of the support group, that's a lot of why the reason I refer them to support groups, just so they can talk to other people who have gone through similar experiences. Because sometimes that's therapy in itself. But there is also, I've been trying to see if there's like a head and neck survivor group, and therapists associated with that. So I've been trying to see if there's some type of connect that I can do, for our patients here. So to be determined.
That's great. In terms, other than the treatments for the psychology or psychiatry, in terms of offering patients chemodenervation or surgery, have you been able to extend the research to look at those patients after treatment to see how it affects their mental health, or if they come back with any changes that are meaningful that you can assess?
So with chemodenervation, we found that it does help, with their overall scores. These were only single snapshots in time, though. We didn't do continuous surveys, so it's hard to say how much, it helped. The other downfall about our study is that we surveyed everyone at once. So we had a pretty wide range of patients. Some had been receiving treatment for quite some times, others had just started. So that was one pitfall of the study, is that it would have been ideal to capture people at their diagnosis, but that's a little hard because I often don't see people until they have been diagnosed for many years. So I really just wanted to get something out before trying to do, a study like that. My goal is to look at the surgical aspect of it because we know that chemodenervation does improve, their overall appearance. So that's the plan for the next part of the study, to see how chemodenervation helps. I've also found that, something else I'm looking at is, like I talked about the gender difference in terms of the majority of my patients are female. I'm trying to understand what are the barriers to treatment. So is there any type of, psychological component where, they view it as cosmetic, and maybe that's why men don't come, because they view it as, maybe taboo to be receiving Botox. Um, we also found that on average, our patients drive 3 hours to come see us. So they're traveling really far. I have patients coming 6 hours away to come see me. And I'm in Middle Tennessee. I'm not, like in Alaska. There are other neighboring states. But when we also looked at the providers providing facial paralysis care in the state of Tennessee, it was clustered to us at Vanderbilt. So there is,
Yeah.
despite me feeling like there's a lot more of us who treat this disease, it's still not as widespread as I would hope. Um, so some barriers we've been looking at is providers who are capable of doing this, how long patients are driving, the cost of taking off work, the cost of coming here, the psychological component of it. Do you view this as a medical condition versus a cosmetic condition? And then just that repeat treatment every 3 to 4 months. But surprisingly, in just some of the preliminary data we found, is that a lot of people, almost 90%, say they will continue to do this forever, because that's how big of a difference it makes. And I think you can then find that a lot of these patients are also seeing a psychological component and well-being component to it. I will say that some of this data is biased because these are our patients who are coming over and over again. It's hard to capture those who don't come back, and I'm trying to find a way to do that through more nationwide data. So I will, make that side note about it. But it's just powerful how much it can make a difference. And I think if we can really refine our surgeries and make those a more longer lasting. So maybe you only have to get Botox every 6 months instead of every 3 to 4 months. That could really have a huge impact for our patients. So yeah, I'm trying to look at it. It's just a little harder to see
Yeah.
kind of the duration of it.
Well, that's fantastic. I mean, I think I look at this world of facial reanimation in the sense of a lot of the surgeries have already kind of been created. A lot of the methods that we use for treatment have already been out there for some time, and we make some minor modifications. But a lot of the minor modifications we do are basically reverting back to previous techniques that people used and then just went out of vogue. But I think as we as surgeons mature, one of the things that we aren't really taught in training, correct me if I'm wrong from your training, is, we are taught put Botox in these locations. Okay, add a couple units here. Okay, try this location once you've got these areas. Oh, this is a little new. We'll try this, or this surgery adds this nuance. But we don't really get training in telling a patient, like, I'm going to do my best to make you whole again. I'm going to do my best. I'm going to do my best to make you feel like you did before this, thing happened to you. And it's, whether it's a reconstructive patient, or a patient with, facial synkinesis, you're never going to get them back to where they were before, but you want to get them to a place where they feel like they were. And I think that's something in the literature and our research that has a lot of opportunities for us to really make some headway. And so I really appreciate, you and your colleagues putting together this study, because I think it's fantastic. We've done some interviews and we've looked at patients and trying to find out where the disconnect is for skull-based patients. Recently we published a paper looking at patients' perceptions and their experiences with interview by doing surveys. How much did they really know, and how much did they really learn about the risk of having facial paralysis after having a vestibular schwannoma removal? And while 99.9% of patients said that they were informed consent included facial paralysis as a risk, once they developed it, less than 25% were ever really given any educational materials or told this is where you go and this is how you get treated for it. And that was a big survey of over 200 patients, but it was biased because it was Acoustic Neuroma Association patients, and it was the patients who filled out the survey. So obviously those are the patients that care the most about it. And so it is hard to get a level playing field, but anything we can do just to get more information about it that we can then take back to our colleagues and say, hey, if you're a neurosurgeon, this is what your patients are saying. If you're a neurotologist, this is what your patients are saying. If you're a neurologist or a family medicine doctor who sees Bell's palsy, which they do all the time, think about this just a little bit differently. And I think, whether we can get them to the psychologist or not, we can at least educate our other medical professionals to make it a little more important in their busy practices to then think about it, and maybe we can get some help in that arena.
Yeah, so that is such a great point because it's just every patient I see, and I would be interested for those guests who are on who are on this meeting, if you don't mind putting in the chat, if you're willing to share just how you found out about help if you do get treatment, because I think spreading the word and the awareness is what I've been trying to do, but it can be so hard. I tried, through talks like this. I try through CME courses with family doctors. I try to meet the neurologist. And I think many people still don't understand that there's a lot that can be done for Bell's palsy. And that because you get lured into this false sense of, well, 70% of people recover without any sequelae. But I don't know if that's necessarily a true statistic, because some studies show anywhere between 15 to 70% develop some type of synkinesis or post paralysis disorder. And so really not we as facial nerve surgeons understand the disease burden, but the people who are they seeing first, the emergency room doctors, the neurologists, the family care medicine doctors, the primary care medicine doctors, I don't know if they truly understand that, and if they truly understand what is available in terms of treatment. So I think spreading the word, spreading awareness about it, and then understanding the disease burden it can cause and the other types of sequelae. The other thing I wanted to talk about is there's lots of data just in terms of our head and neck cancer patients and their survival, and a big support system has been a big part of how well they do, but also treatment for depression, anxiety. And so something my head and neck colleagues here are trialing is actually doing an SSRI during treatment for head and neck cancer. And so that's something I'm considering if we could potentially do for our facial paralysis patients, and see how does that affect their outcomes and their rehabilitation after any type of facial nerve surgery or facial paralysis, and how does that affect their overall outcomes. Because like I said, there's just such a huge mental health component, and if you don't have that support system, even if you do, it's still an everyday battle. So I think spreading the awareness is the first priority, so patients can get to where they need for treatment. Because like you said, I have a very long conversation before we have Botox. What I tell patients is that this is going to be a journey. I'm not going to get it right the first time. I may not get it right the fifth time. It's going to be tailoring the treatment specific to you, because we do not know how the nerve regenerates. And until we figure that out, I will never be able to give you the face that you had prior to whatever the injury was. But my goal is to get you to a better place, that you're comfortable, that you feel more symmetry, you feel like your function is better, but you have to be patient with me. So I ask most patients to commit to a couple treatments, because if you just give up the first or second treatment, we can't make any progress. So I ask people to commit to a couple treatments for us to work together to try and figure out what's the best treatment for them, what they like. I also have patients come in between treatments, so I can see the Botox at their full effect. And then from there, I'm like, okay, well, I could add a little bit more here or a little bit more there, and really get them to a better place. And then if they're like a long-term patient who feels like something's not working, I have them come back. So a lot of this is open communication. And sometimes you can't see it. It's more what they feel. They're like, oh, I have this tightness in my cheek, or my neck is really tight. And so it's really just a lot of it's communication and figuring out what's working for them.
Yeah, I think you're hitting the nail on the head, and I'm sure our audience is probably, feeling like you actually understand what they're going through, and very few people do, even their spouses. And a lot of times I personally find that patients really can't articulate it, and so we are the ones articulating it for them, and then they realize that's what's going on. In the patients you mentioned, there are rarely patients who come and, they're skeptical of the chemo denervation or Botox. And not that we convince them, but I do think by um, not just empathizing, but by being able to articulate what they might be experiencing, or letting them know, hey, this is not necessarily a cosmetic medication, but it can release the tightness, or it can allow you to not focus on the tightness and allow you to focus your attention on something else, not distract you. And so, if for anyone in the audience, and if you are considering going to see a provider, and obviously we are just two of a few doctors in the country that do this. But if you're on the fence, I would definitely recommend and stress to those patients that it doesn't have to be a cosmetic change. It can be what we would describe as a functional change, or releasing tension or something like that to help. In terms of your patients and with chemodenervation for synkinesis, are there patients in your population where you might say, someone comes in and not even and just skip chemodenervation and go to surgery in certain cases? And what would that type of patient look like?
Yeah, so that's a great question. And I do want to make another comment on something you said, because I think you really understood what some people are going through, in that sometimes they can't articulate things and they can't articulate what they're feeling. But since you have seen so many of other patients with similar symptoms, you're like, well, in some of my patients, they experience this, or, I treat them here and that makes a big difference. And they're like, yeah, that's exactly what it is. And in my patients who are skeptical, I had one patient who was like, well, Botox is just cosmetic and this is just a cosmetic difference. I don't want to do it. I finally, at some point she was like, okay, I'll try it. And now she's a long-standing patient and I've done surgical procedures on her, and it's just made such a big difference. And it brings such gratification that I'm able to help her. In terms of surgical procedures, so for patients who are synkinetic, so for the non-flaccid patients, I will offer surgery, right away. But for the synkinetic patient or the non-flaccid facial paralysis, I don't. So I wait 2 years to make sure that we have a full onset of what their synkinetic picture is, and then before I will offer any surgery. And I also do like to treat them with Botox, usually at least one round, so they have some idea of what a potential surgery may be. The option is, I haven't had this yet, most people agree to it, but I guess if someone was coming from far away and I didn't have the option of, multiple visits for Botox, the reason I like to treat them with Botox first is because I want them to see what surgery may potentially be like. And I think that's the best way that you're able to see, okay, so I might get this change in my smile, but my eye may still feel tight, or my brow may still not elevate. And I think it's very important, because sometimes the surgeries are unpredictable and your outcomes are not as predictable as you want them to be. And most people still need Botox afterwards. So I think that's an important first step. Another big part of my practice that I do with these patients is lidocaine injections. So I'll see them for Botox, I'll inject them, and then I'll do a lidocaine block. And that helps me determine, okay, if I do a DAO myectomy, so cutting one of the depressor muscles to help release the smile, I'll inject it with lidocaine, targeting the muscle versus the nerve to weaken it, to see, does that elevate the corner of my mouth? And does that give me the type of smile that I think I might like? Or injecting their platysma, trying to hit the cervical branch, to see, does that give me release of this tension? Or even the midface, seeing if that helps give them a little improvement. I like those lidocaine injections. And then I do a ton of photo documentation. So I take photos prior to injections with Botox. I'll then use the lidocaine injections, take it right after it, label the different types. And it's just so powerful. Even with my patients who I'm doing Botox and I see them in between, it's so powerful seeing that difference, because Botox takes 1 to 2 weeks to see the full effect. So you have a gradual onset of that change, and then it wears off slowly. So it's very easy. You just get accustomed to how you look. It's very hard to see those differences. But when you actually compare the differences between the pre and post treatments, people can really see that difference and say, oh, wow, you're right. My eye is a lot more open when I smile or when I pucker. Or the symmetry of my brows. I know it's so, it's much more obvious when you compare those pre and post treatment. And then I'll do the same thing with those lidocaine injections. I'll take a pre-injection photo and then post-injection photo, and then compare and say, okay, yeah, I mean, potentially doing a neurectomy or doing a myectomy could get you this result. Or no, it's not really as much of an improvement that I want. And I think that really gives people empowerment. It gives them information. It really helps with their expectations from what they might be able to achieve with surgery, because these surgeries are not reversible. And so what you do is permanent. And I would hate to make it worse because they've already gone through so much. So I think the more videos, photos you can have to empower people to really have them understand how this is, what we can accomplish and what we can't accomplish is very important. I'm also
That's
a
great.
conservative surgeon, so I want to treat them and make sure they're on board before jumping to surgery.
No, I think those are all extremely valid points. I mean, just listening to you talk with the injections, that's not something I typically do for lidocaine in my practice. And, just getting ideas, just hearing how thoughtful you are, I think that's super helpful. And for, your residents that you train, I'm sure they appreciate that as well. One thing you mentioned that I think is a question or something, a point that I think every patient who listens to this today or who listens to in the future really needs to take away. The surgical recommendations for synkinesis surgery or for non-flaccid paralysis really are not reversible, are not things that most surgeons would choose to do without first knowing the patient really understands the risks. And also that even after having those surgeries, whether it's removing a muscle or removing some nerves, most patients will still need Botox afterwards. So if you're not comfortable getting Botox before, you probably still will need it after, and it's something that you need to at least be open to, because it's very, very, very rare that surgery alone can combat this. And another point you made in our eyes, if a patient, and this might be something that maybe we collaborate on or you collaborate on with someone else, but if a patient has a certain low threshold on a anxiety or depression scale when they come in and they're not currently taking one, and you notice that there is a disconnect between the way they rate themselves and the way you rate them, it may be worth trialing them on an SSRI, or if it's not something you're comfortable with or I'm comfortable with, sending a note to their PCP, who probably does prescribe a lot of those medications. Mm-hmm. And so it may be that while the therapist is not someone that we can get to as easily, maybe bringing in their primary care physicians. And sometimes it's not just a family medicine or internal medicine. I noticed in my female patients, a lot of their primary care doctors are their OBs, who they just hold on to for primary care. And they obviously are also very versed in these medications. Or it may just become something that plastic surgeons like you or myself, whether we like it or not, bring into our toolbox. Because as you know, they're very, they're well tolerated, and they're probably a medication that we need to be familiar with because a lot of our patients are on them. So it might be something worth talking about at one of our next meetings, even to see what people's comfort level is using those medications, because especially in this patient population, or maybe in the cancer population, who a lot of us deal with as well. So those are all really great topics that you brought up.
Yeah, that's a very valid point. The bringing the primary care physician in, I think, is in a much easier way to access that type of care. And your other point is that for our patients who have paralysis secondary to cancer, you're essentially being hit with two different things. You're being hit with your paralysis, but you're also being hit with a cancer diagnosis, neither of which are easy. So really making sure you have that type of care, I think, is important. And if we can get more people to buy in to the care team and improve it. But yeah, agreed. It's something that definitely has to be in awareness. And it just reinforces the fact that if you're not ready, if they don't seem like they're in a good headspace and ready for surgery, that these are surgeries that can be done at any time. You're not on that time clock like you are with flaccid facial paralysis. So really making sure that the patient is ready for it and the expectations are met, and they have a good understanding what they may be able to achieve, I think, is very important.
Great. We are coming up on the end of our time, but we do have some questions. So I will read them out to you if that's okay, and then let you give your answer. So this is Julie. She wrote that Facebook groups were my lifeline when I was diagnosed with an acoustic neuroma and later facial paralysis. I was not given information about how to deal with it, but when the synkinesis set in, she was recommended to see me. Oh, it's one of my patients. And then so she recommends Facebook for support groups and for referrals. And so are there any specific groups that you send your patients to? Are there any ones that you find helpful? And we can put those into the chat if you happen to know them. If you don't, it's okay. We can ask our patients.
I'll have to look. I'll have to give them to you afterwards. I don't know the exact names.
Okay.
They're on Facebook, but
Okay,
I can
we'll
send
make sure to get those to the group.
Yeah.
And if any patients or and sorry, not patients, but if anyone in any of the audience has ones, please put them in. Let's see. Okay, here we go. This is Jamie, who writes that I was diagnosed with Bell's palsy in September 2024, so about 6 months ago. I've healed after 4 months, but have since developed synkinesis. 2 questions. Does synkinesis develop due to receiving e-stim during the first few weeks of diagnosis? And the second question is, have you seen success in patients receiving trigger point lymphatic drainage massage? So I'll let you go with the first question regarding your opinions on e-stim.
Yeah.
And go to the next one.
So great question. Very controversial question. And I'm actually starting to look into electrical stimulation. So Dr. Loyally, who is at Oregon, this is something that she is also looking into. And if you actually look, so the general consensus amongst most facial nerve surgeons who you talk to, they hear electrical stimulation and they cringe. However, if you actually look at the data and you look at the studies, there is very compelling data in peripheral nerves and regeneration of the nerves. So the question is what was the exact stimulation? What was the dose they were receiving? How often? And were they targeting the nerve or were they targeting the muscle? There's newer studies, and we actually are we're just completing a systematic review looking at all electrical stimulation and facial paralysis to determine, is it harmful versus is it helpful? And the studies that show that it's harmful, it's just it's varied. There's not good data on it. There's actually more data showing benefit. So I don't think I can give 100% answer and definitively say that it's what caused it versus not. I think it's going to be an area of study to really determine, can electrical stimulation help versus harm? I know the consensus used to be that it was harmful and to avoid it, but I think there's going to be newer and newer data showing that it could be beneficial.
Great. The second part of that question was, do you have any experience or have you seen success with something called trigger point lymphatic drainage massage?
So I haven't. There was a device during fellowship where they were doing, it was kind of a trigger type massage device that you could wear. I get a lot of questions from my patients about acupuncture, about dry needling. That's actually another study we're doing, is dry needling, where we have found some improvement in symptoms, not necessarily synkinesis, but their tension. I tell everyone, though, there's no strong, robust data showing improvement. So if it's something that you feel helps, but it's not breaking the bank, so don't spend tons of money on it. It's okay to do it, but just realize there's not data demonstrating one way or another if it helps.
Okay. This is actually the same person put another question. What's your experience using Upneek? Have you recommended that to any of your patients? The eye drop?
It's pretty few. Most people tolerate it okay. It was on back order, so it was a little hard to get. But for patients who get ptosis from Botox, they can get like 2 millimeters of elevation if it's really bothering them.
Okay. This may or may not be something that's in your toolbox. It has to do more with facial PT, I believe.
But sorry, real quick. With the Upneek, I actually do I do Botox over Upneek. The Upneek was for a ptosis secondary to Botox. For patients with droopy eyelids, I'm actually pretty aggressive. I inject pretarsal, so that's right here near the eyelashes that not everyone does. I do a very small amount, and I find that people have that droopy eyelid because they're actually very synkinetic. So I prefer Botox over Upneek.
Okay. So by injecting in that pretarsal region, you help them to open their eye a little bit more?
Mm. Yeah, so if you ask them to like pucker, you'll notice their eye like squinches in medially, and it's usually that pretarsal muscle. And I'll do like one to 2 units, very superficial on the skin, on the pretarsus. Like I said, I'm pretty aggressive with my eye injections, and I get some pretty good results with that.
That's great. So just for patients who are wondering if they have that issue, they can talk to their doctor, whether it's an eye doctor or a plastic surgeon or a facial plastic surgeon about, or a neurologist even about maybe trying to put a little injection in there. The downside is if it was to cause a side effect like ptosis, meaning your eye didn't open as widely, it would be temporary, but it would just be something you have to, consider. But if that's a big issue that you have, this could be a great solution. Upneep drops, I don't know if they're covered by insurance. They were not for many of my patients,
I
so they
don't
are
think
out of pocket.
so.
Um,
Yeah.
the question about, someone's asking a question about long-term effects of Botox on the body. If you have any information or thoughts about that, if you have a patient who's asking you, what's this going to
Yeah.
do to my lifetime?
So great question. I get that question a lot because, I would be concerned as well every 3 months. But Botox has now been around since the 1980s. It was developed by an ophthalmologist, and the cosmetic side effect was just a benefit of it. And so I tell patients that I have had patients who are on it for years, and I have yet to see any studies or evidence of any long-term harmful effects.
And then one patient, or one, sorry, I keep saying patients, I apologize. One member of the audience is saying that they've been getting treatment every 3 months with chemodenervation for 2 years, but they're feeling that it's not as effective anymore. What would you recommend a patient like that who is coming into your office and saying they feel like the Botox is not working as long or is not making as much of an impact?
So for some of those patients, I'll shorten the duration. If they're like, yeah, it works great, but then it starts to wear off around 6 weeks, I'll have some patients who are on a 6 week cycle. If you feel like it's not working at all, I try a different preparation, so Dysport or Xeomin.
So maybe treat sooner or, and would you ever treat more?
Sometimes I do. Yeah. If that would be a patient where I'd be like, okay, come back at a month. Let's take photos, see what the result is, because then you as a physician can grade that. And then if I feel like, okay, we can add more, then I would probably add more. If it looks like it's wearing off earlier, then I'll put them on the 6 week cycle of treatments.
And I'm sorry if you mentioned this, I missed it. Do you have a timeline, as in someone has had Bell's palsy or Ramsay Hunt, and then they had it like 6 months ago, and their synkinesis started like a month or two prior. Do you say I want you to go a certain amount of time before you start using Botox, or would you be comfortable injecting them, within that first like 6 to 12 months?
That's a good question. I inject them, or I usually have them do physical therapy first because I think physical therapy gives you a lot of buy-in to the rehabilitation of your face. But I will inject people early. I will tell them that it's going to evolve. It could evolve over the next year and a half, and we may have to change your treatment and how much you are getting. But if they start getting it that early at 6 months, it's usually only going to continue and get worse. So I think it's okay to treat it. I don't know if other people would think otherwise or differently.
Okay. There's a question about kind of a more physical therapy related question about exercising muscles in the face, trying to do that when someone has a flaccid paralysis following acoustic neuroma surgery. The person who was on here was told that it was not wise. If a patient comes into your office and they're asking questions about things they can do when their face is in a flaccid state, do you recommend they do things? Do you tell them just to wait and try not to do too much? Obviously like e-stim is one thing that patients may or may not try, but in terms of facial exercises, what's your advice for those patients?
I I don't think the facial exercise, I haven't had a lot of issues with people doing it. Is this in terms of like if they're flaccid and out or if
Yeah.
they're, yeah,
Concerned that maybe doing too much could cause issues down the road, like cause synkinesis or contribute to it.
it's a good question. And I don't feel like there is, but I don't have studies to back it up. And definitely when they're recovering, I do want them doing physical therapy. In the exact flaccid patient, sometimes I have them do it because people are just so desperate while they're waiting for it to come back. But it, I don't know. Have you read much about physical therapy during that acute phase? And um, I
I
just don't
haven't,
know if there's much data out about it.
I think you're probably right. I don't think there is very much data about it. I don't typically recommend my patients do it. But I don't say not to. If they ask me if they can do acupuncture or if they can do therapy, I say they can do it. I don't tell, I basically set them up for minimal returns, but I preface it that if it helps your mental health, if it helps your emotional health or just your body in general to feel like you're doing something, great. But I will preface it with, um, I don't think it's going to make you recover sooner. And
Yeah.
if I sense that a patient is feeling, because sometimes patients can feel guilty that they're not doing enough, or they put a lot of they put a lot of the load on their shoulders. If I sense that that's what's happening, then I'm pretty quick to start talking about more of the emotional stuff and trying to get them plug them into a therapist that I think working with somebody who can help them talk about their emotions and their feelings, I think would be more helpful. But if someone says, "Oh, I'm going to an acupuncturist or I'm going to a facial therapist," and they're doing these things and they feel like it's helping, I'm not going to necessarily dissuade them, but I tell them that it's not something that I think is going to necessarily make a huge improvement, but it's not going to harm them, I guess.
Yeah, I would agree with that. I don't refer them to physical therapy if they're flaccid, and r- I don't have them do acupuncture, but it's more if you want to massage the face and you feel like that is something that you can do because you want to be doing something, I'm okay with that. I don't think it worsens things.
Excellent. The last two are just comments mentioning how helpful the Acoustic Neuroma Association was for patients. And we are, I believe, I don't know if we're board members, but we are, we sponsor them and they've helped us. And I'm sure Vanderbilt has a strong relationship with them as well. And so for patients who had vestibular schwannoma or acoustic neuroma, that's an excellent resource. I believe there's also some Facebook groups, but we'll make sure that we'll put them into the chat as well and share any resources with anyone who attended if you'd like to reach out to us directly. And then what we'll plan to do is once we get this recording edited, we'll add a closed captioning section for anyone who's hearing impaired because a lot of our patients, obviously, with acoustic neuroma have hearing issues. But really, we just want to thank Dr. Yang for sharing her time with us and for all the attendees for coming and joining us. This has been a fantastic talk, and I can't wait to meet again in person or maybe catch up, via email and we can talk about some other studies we could potentially put together with some of our colleagues. This is great work that you're doing, and I'm just glad that you guys are really taking the time and putting your energy into this region.
Thank you so much for having me. It's always great to see you, and I really appreciate just letting me share this work because it's something I'm super passionate about.
All right. Thank you so much. Have a great day. And as soon as we get this edited, we'll also send it to Dr. Yang so any of her patients and Vanderbilt's website can use it as well. So thank you guys again. Have a wonderful day.